We will go on to Dr. VIPIN SAHNI, a senior eye consultant from Kausalya Devi Eye Institute, Uttar Pradesh. And he is going to be showing us a very interesting video and lot of learning again in it. On to you, Dr. VIPIN.
Yes, ma'am.
VIPIN, you can
Yes.
start.
Yes. I'm presenting IOL scaffold after PCR. This was a case fellow was doing. He was doing a 4 tunnel method and then chopping one by one. So everything was going well. When the last piece came, because of sudden collapse of the chamber, there was a PCR. So before removing the phaco probe, I asked him to put the methyl cellulose first inside the eye. Then the probe was removed and case was taken by me. We took all the pieces of nucleus over the iris and inserted a 3-piece foldable IOL inside the eye. Everything was going well, but IOL turned upside down suddenly. As the lower haptic has gone into the sulcus, I rotated the IOL and put it over the iris. Then I took this small piece of nucleus by phacoemulsification and all the small pieces were removed one by one. It was taken care that chamber should not get deep suddenly or something like that. Then I toppled the IOL using 2 instruments and dialed the haptic into the sulcus. Vitrectomy was performed. Earlier we was not using this tricot. Nowadays we are using tricot. And wound was hydrated and everything was very well. Similarly, there is another case. In this also PCR, I took the case after PCR happened, deposited the pieces over the iris, used 3-piece foldable IOL, lower haptic going into the sulcus, and I dialed the upper haptic over the iris, collected all the pieces over the IOL, and phacoemulsification was done using IOL as a scaffold. It was taken care that chamber does not collapse or get suddenly deep. Phacoemulsification was done. Some cortical matter was removed, vitrectomy was done, and then later on IOL was dialed and wounds were hydrated.
Thank you. Thank you very much, Dr. VIPIN. You showed us different situations of IOL scaffold. So we are coming back to this. Now we do understand the challenge which you showed us in a 3-piece which is used as IOL scaffold, how it can have a very forceful opening, unfolding.
Yes.
Sometimes you can even push the nuclear material down, and in your situation even turned upside down.
Yeah.
And Mohan had said in an earlier situation that if you have a nuclear matter, like in the case of Samresh's case, there was less of vitreous presenting. So he could actually do without an IOL scaffold. But there are situations where there's so much of nucleus matter, you can't be doing a vitrectomy at that point of time to salvage, do clear the vitreous, the nucleus would have gone down completely. Sometimes you may have to introduce the 3-piece IOL, get the pieces onto the scaffold, and then carry on. These are just thoughts which I'm putting forth for 1 or 2 discussion points before we go on to the next speaker.
Absolutely, the vitrectomy has to be done earlier.
Yes.
Before the tricot, use tricot, do a vitrectomy, and then
nowadays we use tricot.
Yeah, do a vitrectomy. Whether you use tricot or not, do a vitrectomy, then put the IOL, and then remove the nucleus.
Dr. Mohan, there is a question.
Yes.
Suppose if we don't flip the lens, how it will affect the vision? Both are biconvex, almost biconvex.
The multi-piece lens, it doesn't matter.
Yes, because you see the already chamber is compromised. Our experienced surgeons, Indian surgeons are very experienced and they can actually flip it. But if you don't flip also, and if you put it like this, also,
it could have been done without flipping, but I wanted to flip,
but
so I flipped it.
I will tell you one thing. Please understand what this ball game very clearly. Once you remove the vitreous there, you don't have, you can just do all the manipulations in the anterior chamber without any fear.
You can
once
clear the vitreous right in front. Don't go deep down.
Yes, once you remove the vitreous. But if you have the vitreous there and you try to manipulate the IOL and you are doing the phaco and you are actually cutting the vitreous also with the phaco, because you do not know the vitreous will be right in front of the IOL when you are removing the nucleus. The nucleus and the vitreous are all entangled. Okay.
Actually,
VIPIN is actually a very experienced surgeon, and he first introduced scaffold and plate.
IOL scaffold is best when the vitreous is less and the PCR is smaller. When there is a large amount of vitreous and a large PCR, we have to deal with the vitreous and then only look at placing the IOL scaffold. Very learning tips and very well